Good morning, everyone, and welcome back. I'd like to remind everyone that before the discussion and as questions are coming up, will people please, when you approach the microphone, state your name and your institutional affiliation. That's really important for the video capture. And those of you that are involved in scoring for the Folkman Award, please turn in your score sheets to myself at the end of the session or to Casey Calkins. The first speaker for our session today is Dr. Catherine Hunter. This year, we are pleased to invite our Grossfeld Foundation scholars to present their work during the plenary scientific sessions. Since its inception in 1991, donations to the foundation have exceeded more than $1 million, and it has provided more than $560,000 in grant support for our young pediatric surgeon scientists, the majority of whom have used these enrichment dollars as a springboard to acquire external funding from the NIH and other sources. Donations can be made on the APSA website. Please join me in welcoming Dr. Catherine Hunter from the Ann and Robert H. Lurie Children's Hospital of Chicago, and my partner, who will be speaking today on defining the role of ROC in necrotizing enterocolitis. Thank you.
Well, thank you very much to the Foundation for their marvelous support of our research. Necrotizing enterocolitis does not need an introduction to this audience. However, despite many years of active research, there's still an incomplete understanding of the underlying pathophysiology of disease and no single cure. However, we do know that increased intestinal permeability is a hallmark of necrotizing enterocolitis. Tight junction proteins are protein complexes that reside at the apical surface of the enterocyte. They include occludin protein, claudin proteins, JAMs, as well as zona occludens. They allow for the formation of a semi-permeable barrier, which is important in the maintenance of enterocyte homeostasis. ROC is a serine-threonine kinase. It's involved in multiple cellular processes, including the regulation of tight junctions, as well as cell death. ROC inhibitors are used clinically. They're used in cardiovascular disease, and they're found to decrease the transendothelial leak and inflammation. The aims in the proposed work that we've been conducting over the past year was to test the hypothesis that lipopolysaccharide and oxidative stress result in ROC activation in NEC, and also to determine the molecular events by which ROC inhibition limits experimental NEC. To test these hypotheses, we use a series of different necrotizing enterocolitis models. The first is a modification of the Barlow et al. Model, where rat pups are induced near term and subject to feeding with formula and Coronabacter sakazaki and hypoxia. This leads to a neck-like state. We also utilize cell culture. CACO2 cells, which is an intestinal epithelial cell line, are exposed to lipopolysaccharide to induce neck-like changes. We also collect human tissue samples. We have control samples, which come from patients undergoing bowel resection for etiologies other than necrotizing enterocolitis, as well as taking portions of bowel from our patients who are subject to NEC-related surgeries. Recently, we've also been able to develop human enteroids. We further validated this model and been able to induce a neck-like state in our enterocytes using LPS treatments. So our first goal was to determine whether ROC was activated in NEC. You can see here in our human tissue samples that there's a robust increase in the activation of the ROC pathway. You can also see that within our CACO2 cells, there's also significant increase in the amount of ROC activation in those treated with lipopolysaccharide, such as our neck-like conditions. When we performed immunofluorescence staining, you can see here that in the control samples, the tight junctions are seen in green. The blue is DAPI staining, which is a nuclear stain. And the red is the ROC protein. You can see that there's a robust increase in ROC protein in our necrotizing enterocolitis pups. When we analyze the occludin distribution and patterns in NEC, we can find that in our human samples, controls, there's the normal staining here with sharp borders at the enterocytes. In NEC, this becomes blurred and there's an internalization of the occludin protein. This is also reflected in changes in the mean fluorescent intensity. our enteroids demonstrated similar changes. Furthermore, we've been able to demonstrate that ROCK inhibition protects against loss of occludin. In our rat pups, you can see this diminished response and diminished quantity of protein in necrotizing enterocolitis. However, in the presence of ROCK inhibitor, you can see that there's a preservation of this normal quantity. And when we looked at this with immunofluorescence, now here red is occludin, you can see that there is a normalization of the pattern and distribution of the occludin staining compared to those with NEC. These findings here are much more similar to the clean as opposed to those with the necrotizing enterocolitis treatments. Furthermore, when we performed H&E staining on intestinal segments taken from our rat pups, you can see that in the animals which were subject to necrotizing enterocolitis treatments, there is a loss of the normal intestinal epithelial integrity. However, with the presence of ROCK inhibition, this preserves the normal pattern. This was also reflected in our intestinal injury scoring seen below. When we looked at apoptosis is seen here in the red staining. You can see that NEC induces a significant amount of cellular death in the enterocytes. However, with the addition of ROCK inhibition to our animals, there is actually a decrease in the amount of this apoptosis, which is quite significant. So in conclusion, ROCK is activated in human and experimental necrotizing enterocolitis. ROCK inhibition maintains normal occludin quantity and distribution in the face of NEC. ROCK inhibition is protective against experimental NEC and may represent an interesting therapeutic adjunct. This is our productivity during this past award period. And again, thank you so much to the Foundation and for all of your support in our research here. Happy to take any questions.
We have 2.5 minutes for questions.
I scared everybody?
Kathy Burnwhite from Miami. Can you talk about the timing of giving the ROCK inhibition? Because that's very important in NEC to make sure it's given after the NEC insult starts, at least in terms of clinical application.
Yeah, so we actually give the ROCK inhibitor within the first day of initiating the NEC-inducing events. So we start our treatment with our Chronobacter sakazaki formula-feeding hypoxia, and then usually within about 12 hours or so, we start the ROCK inhibitor. So it's not a classic pre-treatment to try and answer the question that you're alluding to, but certainly it is hard for us sometimes to know exactly when necrotizing enterocolitis starts before the horse is out of the barn.
The Copy London, thank you for the very nice study. ROCK inhibitor is used also to maintain in vitro intestinal organoids, to make them culture, and they stimulate proliferation. Are you worried about an unregulated proliferation in vivo if you use ROCK inhibitor in this way?
You know, I think the safety profiles need to be looked at. ROCK inhibitor is also a pharmaceutical that has effects in multiple different cells. So one of the things that we've been doing to try and address some of these issues is working with one of our collaborators who has a nanomolecule which will allow us to deliver this ROCK inhibitor directly to the enterocyte. The importance of looking at proliferation, that's also one of the areas that we're looking at, especially with reference to restitution and reconstitution of the intestinal epithelial border.
Thank you.
Thank you.
Thank you so much.
Thanks,
Kathy.
Thanks.
Next, I'd like to invite to the podium Dr. Richard Wu for the Hospital for Sick Children in Toronto, who's going to speak on individual human milk oligosaccharides prevent experimental necrotizing enterocolitis via divergent transcriptomic responses.
Hi there. First of all, I'd like to thank the organizing committee for this invitation. My name is Richard. I'm an MD-PhD student in the lab of Dr. Agostino Piero. And the title of my talk is Individual HMOs Prevent NEC by Divergent Transcriptomic Responses. So to start, let's start with a picture of why this all matters today. So this is a picture taken at SICKIS, and notice how the abdomen of the child is very distended. That's not the healthy baby fat we see in a child, because we take an x-ray, there's tons and tons of gases. And the reason for that is because there's so much mucosal inflammation, such that the intestinal barrier has completely collapsed. This allows the translocation of bacteria into the lamina propria. And the constant fermentation of bacteria causes lots and lots of gases, but it also perpetuates a vicious cycle of inflammation, barrier breakdown, and colonization. So this is a problem. What can we do about this? Interestingly, it turns out depending on what the baby eats in the first few days of life has an impact on whether they get neck or not. Specifically, if the baby is breastfed by their moms, their risk of developing neck is 10 times less. So this begs the obvious question, why is breast milk protective? And this is not an easy question to answer because there's lots of ingredients inside breast milk that are protective. But the components that we decided to focus on are the human milk oligosaccharides, or HMOs. These are non-digestible oligosaccharides that stimulate the host microbiota. So you can think of them as baby fibers. And it's been shown in the last 5 years that if you actually take these HMOs from human donors and give them to neonatal rats, they don't get neck. They're neck resistant. And what's even crazier is that in the last few years, it's been shown that you actually don't need the entire repertoire. You can just like one or two. One example of that is 2-fucosyl-lactose. And if you give that sugar to mice or rats with neck, they don't develop disease either. They're neck resistant. So actually, on an average mother, they can secrete anywhere from 10 to 100 different types of HMO structures. So the question is, well, if one of them protects against neck, do we need the other 99? In other words, are HMOs equal? Is there differences or redundancies in terms of their effects? To address this gap, the aim of our project is to compare the effects of individual HMOs on the intestinal epithelial barrier and to characterize their mechanism of action in the setting of neck. To do this, we got our hands on 5 different HMO structures as shown here. The chemical structure is not that important. But to test their effects, we employ a murine neck model where we gavage fed these formulas into postnatal day 5 pups. And for every single day, we put HMOs, each individual one of them, into their formulas. On day 6 and 7, we induce inflammation by using LPS. And to look at the intestinal phenotype, we use histology, we did immunofluorescence, and looked at inflammation using qPCR. But to get a sense of the underlying signaling pathway, we also did an RNA sequencing experiment. For the sake of time today, I will only discuss the results for LNT and 2-fucosyl-lactose. So the first effect we looked at the terminal ileum to see what is happening at the mucosa surface. As shown on these histology slides, you can see that with 4 days induction of neck, there's venous sloughing, thinning of the gut wall, signs that recapitulate what we see in human neck. But watch what happens to mice that were fed with either HMO 2FL or LNT. In both types of mice, there's a recovery in the mucosal integrity. The gut wall remains mostly intact, just decrease the amount of venous sloughing, and as seen by the histology score, just a decrease in the amount of severity. But these are just rough images to look at what is happening in the mucosal surface. What about the molecular mechanisms? Unfortunately, what happens in neck, one of the changes that occurs is that there's so much inflammation that there's a loss of regenerating stem cells in the crypts. And one of the ways we can measure that is using Ki67. Shown in red, that's the staining for Ki67. And if you just squint your eyes a little bit, you can see at the bottom of the crypt, there's a long line. That's all the cells are proliferating in normal, healthy control mice. But if you take a look at the neck mice, most of that is all destroyed. And that's as a result of all of the inflammation by necrotizing colitis. But once again, with either 2FL or LNT, both sugars, they prevent the decrease in proliferation. So far, I've just shown you that 2 types of sugars, different in structure, both found in human breast milk, can prevent neck and also rescue the amount of proliferation loss with necrotizing colitis. This begs the question, are they similar? Do they exert the same mechanism? To do this, we use Keiko cells. And what we did was expose 5 different types of HMOs onto those cells for 24 hours, and we conduct an RNA sequencing experiment as a way to gauge at all the signaling changes that occur with these HMOs. And showing this heat map on the y-axis, that's a total of 2,500 genes that are changed by these 5 different sugars. And across the x-axis, the 5 different columns, that's each of the individual type of HMOs. These were done in triplicates. Now we can see here that across 5 different HMOs, they completely induce different types of patterns in terms of the cell morphology. If we pay attention to the 2 that we tested in our neck model, we see that 2FL and LNT both induce different target genes on the host cells. So the question is, what do these genes actually do? What types of function do they have on the cells? So using gene set enrichment analysis, we looked at all the pathways that are altered. And one of the pathways that was altered was glycoproteins. So normally the gut is lined by thick layer mucus, and all these glycoproteins help to decrease the adherence of bacteria. And what we see with LNT, the second sugar, is that it actually increases the amount of secretion. And just to confirm that effect, we also use qPCR. And as you can see here, the LNT is able to increase higher expression of MUC2 and TFF3. So this begs the question then, from this little RNA sequencing scavenger hunt, does 2FL LNT actually induce different levels of mucin expression in the neck mice? To do this, we use immunofluorescence, and we're seeing for MUC2. MUC2 is the most predominant form of mucins expressed in the gut. As shown that in 4 days of induction of the neck, there's a decrease in the amount of MUC2 staining, shown in green. But watch what happens to cells that are mice treated with 2FL or LNT. In both cases, there's recovery of the amount of MUC2 staining, but in LNT fat pups, they just blow up like fireworks. There's a huge surge of amount of MUC2 expression in these mice. And just to confirm this result, we can also use both counting as well as MUC2 expression using qPCR. So this begs the question then, are these, clearly they're both protecting against neck, but one is slightly different. LNT increases the mucin expression a lot more. So does this mean that LNT is better than 2FL? So the next thing we did was we looked at inflammation, and the answer is no. Because when we looked at inflammation for IL-6 and MIP2, actually the benefit of the sugars were all flipped. Instead, it was the 2FL that decreased the amount of inflammation on the host mucosa, whereas LNT FET pups had higher expression of inflammatory markers. So in summary, I hope I'm showing some evidence today to show you that HMOs can protect against neck, but the mechanism of action may differ. And an example of that is that LNT induces mucin expression, whereas 2FL lowers the amount of inflammation on the intestinal mucosa, suggesting a structure-function relationship of HMOs. And at the end, why does this all matter? Well, we're going to go back to the clinical picture, which is the sick baby right here. And I really like this line in the Nature Review a couple of years ago that asked the question, are human milk oligosaccharides the magic bullet for neck? And I think the answer is that perhaps. But I think what our research shows that that magic bullet might not be the same. There might not be one single magic bullet for all babies. In fact, that magic bullet might be different depending on the phenotype we see in the babies. And in fact, it might be a combination of bullets that might be important to prevent neck. And with that, I'd like to thank the lab as well as the funding sources. I'll take questions.
Thank you. That was a very interesting and well done study. I have a question related to one of your observations and less related to neck, which is it appears that you've shown that these oligosaccharides have a positive effect on stem cells. So my question is, in your field, have people looked at oligosaccharides and their effects on different populations of stem cells, not necessarily in the gut, but in other places and progenitor cells?
You're absolutely, I think you hit the nail on the bit there. So after we saw that observation, I think that right now in the past 5 years, there hasn't been a lot of studies on that. And that's actually one avenue that we're currently pursuing in the lab. And just to give you offhand, we do see that there's changes. I mean, you saw how profound the changes were with the proliferation markers. But right now, there's no studies published, but that's an avenue that we're pursuing. One simple way we can test for that is just look at the amount of LGR5 positive stem cells that are expressed after exposure to these oligosaccharides. And I think that preliminary results in our lab show that there has been some changes. Yeah.
I'm sorry, in the interest of time, we're going to need to proceed to the video tribute for Dr. Santulli. Thank you so much for your presentation. This session is dedicated to Dr. Thomas Santulli, who is APSA's 11th president. The video was prepared by Dr. Brian Craig, who's the junior fellow at Lurie Children's Hospital in Chicago.
Dr. Santulli was born and raised in New York City, growing up in Brooklyn and attending Columbia for college. He went to medical school at Georgetown in Washington, D.C., and then returned to New York. He completed his residency at the New York Polyclinic Hospital, pictured on the left, and started in practice at Baby's Hospital in 1945, pictured on the right, where he would practice for his entire career, retiring in 1980. Dr. Santulli is pictured here on screen right, with George Humphreys in the middle, who was the chair of surgery at Columbia when Santulli became chief of pediatric surgery. and with Edward Donovan on screen left, who preceded Santulli as the chief of surgery at Baby's Hospital. Dr. Santulli's research efforts focused on neonatal surgical problems, including intestinal atresia, meconium ileus, necrotizing enterocolitis, and anorectal malformations. His work ranged from the basic biology to clinical outcomes to specific technical considerations that he felt were important in determining clinical outcomes. A prime example of his technical focus was his version of the enterostomy and anastomosis used to manage both meconium ileus and intestinal atresia before the advent of TPN. Almost like a mirror image of Dr. Bishop's and Dr. Koop's approach, Santulli chose to use the proximal limb of divided intestine to form the stoma, with the distal limb anastomosed in an end-to-side fashion. In his writing, he stressed his belief that the most important factor in the management of these neonates was the decompression of the proximal obstructed limb, and that led him to construct the enterostomy as he did. On the right is pictured how he would progressively clamp the stoma while infusing flush distally to clear out the inspissated stool and to encourage the passage of intestinal contents downstream. In 1958, Dr. Santulli started his pediatric surgery training program in New York. That same year, Willis Potts from the Children's Memorial Hospital in Chicago published a lengthy editorial in JAMA about the emergence of pediatric surgery as a distinct specialty that demanded unique expertise. 23 years later, in his 1981 presidential address at APSA, Dr. Santulli reflected on the progress of the field in relation to what Dr. Potts had said. Santulli argued for the expansion of the number of annual trainees to contend with the ever-increasing number of premature infants who were surviving at earlier gestational ages and lower birth weights, and for pediatric surgeons to take a central role in both the operative and non-operative management of these infants. He even proposed a split in pediatric surgical training, with a 2-year clinical track for most programs and a 3-year academic track to be offered at research-focused institutions. When he died from lung cancer in 1997, Dr. Santulli was memorialized with an obituary in the New York Times, indicating the magnitude of his impact on the development of pediatric surgical care, both in the New York area and nationally. Dr. Santulli's career truly serves as a model for building a thoughtful, inquisitive academic practice and for how to remain focused on improving the care we provide as pediatric surgeons.
I'd like to invite to the podium Jason Frazier from Children's Mercy in Kansas City on behalf of the Midwest Pediatric Surgery Consortium. He will be speaking on sutureless versus sutured abdominal wall closure for gastroschisis, operative characteristics, and early outcomes from a multi-institutional consortium. Dr. Frazier.
All right. Thank you for allowing us to present our work here today. We have nothing to disclose. The sutureless closure technique for gastroschisis has gained popularity and interest since it was first introduced in 2004. However, there's no large comparative data present. To that end, we sought to report and compare the outcomes of neonates treated with the sutureless and the sutured gastroschisis closure across our consortium. We therefore performed a retrospective review of the 11 centers of the Midwest Pediatric Surgery Consortium from 2013 to 2016. Patients with complicated gastroschisis, which was defined as perforation, ischemia, atresia, and death, were excluded from the analysis. We then compared sutureless versus sutured abdominal wall closure for gastroschisis. However, recognizing that the use of a silo may confound this analysis, we then broke patients into 2 groups. Those that had a silo-assisted closure were compared, and then those that had a primary closure were then compared. On the left, you can see a typical sutureless closure method. On the right, you can see a sutured closure method. Sutured closure was defined as sutures placed in the fascia in the operating room. There were 394 patients identified for this analysis. 79 were excluded for complexity, and this left 315 total patients for analysis. 248 patients had a sutured abdominal wall closure. 212 had a silo first and then had a sutured closure, and 36 had a primary sutured closure. 67 patients had a sutureless closure. 37 had a silo and then a sutureless closure, and 30 had a primary sutureless closure. We then compared the sutureless and the sutured closure outcomes. Patients found no difference in the median length of stay, gestational age, or birth weight between the two groups. Furthermore, there was no difference in total days of TPN, time from closure to first oral feeds, and time from closure to goal feeds between the two groups. Patients with the sutureless closure technique had less, significantly less, surgical and deep site infections and less antibiotics use after closure. There were, however, no differences in antibiotic days after closure or antibiotic use prior to closure. Patients that had a sutureless method had less general anesthetics and less ventilator use outside the OR, in combination with less time on the ventilator as well. Breaking this down into our subset groups, the patients that had a primary closure, we found that patients that had a primary sutured closure had less total days of TPN. In comparison, patients that had a primary sutureless closure had less anesthetic use, less ventilator use outside the operating room when you compare that to the group that had a primary sutured closure. Patients that had a silo and then a sutured closure, patients that had a silo and then a sutureless closure were found to have less general anesthetics, less ventilator use outside the operating room, less days in the ventilator, and less antibiotic use after closure. In conclusion, patients that had a sutureless abdominal wall closure had less general anesthetics, less antibiotic use, less surgical and deep space infections, and less time on the ventilator. They had similar time to initial and goal feeds, and this led to a similar hospital stay between the two groups. Our next direction will be to determine the long-term outcomes and complications of this cohort. Furthermore, we'd like to determine the umbilical hernia rate both in the short and the long term, as well as examine the umbilical hernia repair rate in this group. We will then perform a prospective sutureless protocol across our consortium with the overall goal of improving outcomes in this cohort. Thank you. I'd be happy to take any questions you have.
David.
Hi, David Rothstein, Buffalo. Thanks. As a huge fan of sutureless closure, I'll ask a question just to ask the question. Part of our complications or extended differences probably results of general anesthesia, and we've all learned to do sutureless without general anesthesia. Have you guys entertained or have any subgroups that may be done under spinal for those of you, somebody, who prefer to suture, maybe think that's a better cosmetic outcome, or a shorter, decreased rate of hernias? So is there a role for maybe spinal anesthesia or even tap blocks?
Thank you, Dr. Rothstein. I think that's a good point. That's not specifically something that we examined in this result. We just specifically looked at anesthesia or non-anesthesia. But I think that's always something to consider, especially if your local hospital and local anesthesia group supports that.
Yes.
Number one, I congratulate you for your nice work. Did you have cases of sutureless that you had to convert to suture?
Yes, sir. Thank you for your question. There were 2 patients we had to convert from sutureless to sutured closure. Both of those patients actually developed abdominal compartment-like symptoms. And so I think that's something to definitely think about as you are selecting to put patients in a more sutureless closure technique, is you need to continue to examine them just like you would for a sutured repair. And make sure that your dressing's not on too tight or they don't have other physiologic changes that make you to look for that. But yes, we had 2 patients that we had to convert from sutureless to sutured.
The second is just a comment. I would say that your picture of the suture case that you put there is a little bit biased. It doesn't have to look like that, and it can look as normal as the cases that you showed later, because you need to leave the stump of the umbilical cord and you suture the round edge of the skin to the base, to the gelatinous base of the stump with a continued rapide, and it looks just perfect when the cord detaches. If you do it sutured.
And before you leave the microphone, would you please state your name and institution for the video?
Luis Martinez from Tampa, Florida.
Thank you.
Thank you, Dr. Martinez. I appreciate the comments about that.
Any other questions? I have a question. You, in your group that was the 212 patients that had the sutured closure, and you mentioned that they went to the operating room. Did every patient go to the operating room, or were any of those done in the NICU? And do you think that if you did that in the NICU, you might see a change in the anesthetic and ventilator days?
Yeah, all of the 212 that had a sutured closure after a silo was done in the operating room. And I think obviously that would be somewhat institution specific where and how you can do that repair.
Hi,
Yes.
Shai Han from Portland, Oregon. I was wondering if there are any differences in the baseline patient characteristics between the sutureless group and the sutured group.
Yeah, we did not see any differences between the baseline characteristics. Thank you for your question.
Okay, thank you very much.
Thank you.
Next, we have Charles Lays from University of Wisconsin-Madison on behalf of the Midwest Pediatric Surgery Consortium, who will speak on changing the paradigm for management of pediatric primary spontaneous pneumothorax. A simple aspiration test predicts need for operation. Dr. Lays.
Thank you for the opportunity to present this work. We have nothing to disclose. So the optimal initial management for primary spontaneous pneumothorax remains unclear. The majority of us utilize chest tube management, which is associated with prolonged hospital stays and high recurrence rates. As a result, some surgeons have begun to offer primary VATS. However, there's concerns that this could overtreat the population and may not be cost effective. The British Thoracic Society has published guidelines recommending simple aspiration as the initial intervention, though this is not commonly utilized in North America, nor has it been well studied in children. So the purpose of this study was to evaluate the efficacy and role of simple aspiration in children in an effort to define a more streamlined algorithm. Our hypothesis was that simple aspiration may prove useful as a test to predict failure of non-operative management and thereby justify earlier surgical intervention. This was designed as a prospective pilot study across 9 centers in the Midwest Consortium. The aim was to enroll 33 patients over 2 years. All the patients were first presentation with spontaneous pneumothorax, age 12 to 17, and all of them needed to have a large enough pneumothorax to warrant intervention. The aspiration procedure was performed with insertion of a small catheter, then a chest x-ray obtained to assess lung expansion. The catheter was uncapped and they were observed for 6 hours, then another chest x-ray obtained. We elected to leave the catheter in place during observation such that it could be utilized if aspiration failed. If the pneumothorax was small, stable, or resolved after 6 hours, the catheter was removed and the patient sent home. At any point, if there was a failure of aspiration, this was managed according to surgeon discretion with the option to either place the existing catheter to suction or proceed to VATS. And all patients were followed out to at least 1 year. So we enrolled 33 patients. We found that aspiration was successful in 16, while 17 failed and required further intervention. Within the failure group, there were 5 managed with an early decision to proceed immediately to VATS, while 12 went on to chest tube management. Of the 12 chest tube patients, 5 had persistent air leak and ultimately required VATS during that hospitalization. 7 resolved and went home, but 5 of them recurred. So overall, 10 of 12 patients failed chest tube management after failure of aspiration. If we view aspiration as a test, aspiration predicts need for operation with an 83% positive predictive value. Recurrence after successful aspiration was 44%, which is consistent with historical data from chest tube management. We compared those who passed versus failed aspiration and found no baseline differences other than after 6 hours, the pneumothorax was larger in the failure group as expected. We modeled time to recurrence or VATS as a Kaplan-Meier curve, comparing successful aspiration group against the chest tube management group. This excludes the 5 patients managed with an early decision to proceed immediately to VATS after failing aspiration. The difference here suggests that failure of aspiration does risk stratify patients into a group that is likely to fail non-operative management. Length of stay data show some high outlier length of stay in the chest tube management group, especially in the 5 that required VATS during the initial hospitalization. As compared to the 5 patients managed with early VATS, the length of stay was shorter. We conclude that simple aspiration as a test predicts failure of chest tube management with 83% positive predictive value. Failure of aspiration, therefore, may be utilized to justify an early decision for VATS and potentially avoid chest tube management altogether. We propose this algorithm for patients presenting with spontaneous pneumothorax. Those with recurrent disease can proceed directly to VATS. For non-recurrent disease, consider simple aspiration, and if that fails, proceed directly to VATS. Thank you.
Daryl Cass, Cleveland Clinic. Maybe I missed it, but can you explain again this issue about recurrence in the aspiration group that you defined as successful past the aspiration? Because looking at your Kaplan-Meier curves, it looked like this recurrence sometimes occurred within the first day or two after that, which then I wouldn't necessarily categorize that as a successful intervention, as opposed to if they went home and then came back a week or two later.
Thank you for that comment, Dr. Cass. So successive aspiration was, we called it success if they went home, after 6 hours of observation with a stable, smaller, resolved pneumothorax. The earliest recurrence in that group was at 14 days. So I think you could argue, is that continuation of the same event, or is it really a new event? But a continuation of the same disease regardless.
Hi, I'm Ann O'Connor from Lurie Children's in Chicago. I was wondering if you could explain how exactly your simple aspiration happens. Are the patients asleep? Is it done by surgery? Is it done by radiology? And maybe a little bit about the strategies for cost control in that situation too.
Yeah, these were done in the ER, on patients presenting through the ER. Each site was allowed to kind of define what worked for them in terms of the logistics of that procedure. The vast majority were performed by interventional radiology with ultrasound or fluoro guidance. I don't know for sure how many of them got sedation for that, but we do think there's a cost advantage because many of these patients do not require admission to the hospital that can be observed in the ER.
Sharif Emil, Montreal, thank you for presenting this very intriguing study. Just to expand on Daryl's question a bit, I'm still not quite sure. I think if I understood correctly, you said in your success arm, if it was stable or had resolved, that was success. So does that mean if you aspirated and then on the subsequent chest x-ray, the pneumothorax was still the same but hadn't increased, that was considered success? Could you just, because it's so central to your study, I'm just curious if you could explain to us what success again really meant.
Yeah, so success was defined. When we were designing the study, we looked at a series of x-rays, and kind of as a group, we all agreed on what we would consider a small enough pneumothorax that it would not require any further intervention. So in order to enter the study, the patient had to have a pneumothorax large enough that we would want to intervene on it, and then after aspiration, it had to be smaller. And the criteria were the apex of the lung had to be above the top of the fourth rib, as viewed on an AP photograph, posterior aspect of the rib, or laterally, it had to be where the lung met the chest wall, had to be at the sixth rib or higher. So that was kind of defined as small enough that it didn't need anything else done. So there were some pneumothoraces there was a small residual pneumothorax there after aspiration, but it was stable after 6 hours of observation. So we took that to mean there's no continued air leak and the patient is safe to go home.
Okay, thank you very much.
Thank you.
Next, I'd like to invite Dr. Timothy Bouts on behalf of the Pediatric Surgical Oncology Research Group, who will speak on thoracoscopy or thoracotomy for the management of metastatic osteosarcoma.
So thank you. First of all, I am pinch hitting today. Todd Heaton was going to give this presentation, but he hurried back to New York last night to be there for the birth of his first child. So congratulations to Todd. But today I'm privileged to present a study on thoracoscopy versus thoracotomy for pulmonary metastasis and osteosarcoma, and this was conducted by the Pediatric Surgical Oncology Research Collaborative. Doesn't want to advance. Can you go back? Could you go back, please? So pulmonary metastases occur in 40% of all osteosarcoma patients, and it carries a poor prognosis, and that prognosis has not improved in recent decades. Previous studies have identified several prognostic factors in metastatic osteo. This includes bilateral disease, the number of metastases, and pathologic response to treatment. More strongly associated with outcome was the timing of metastasis, whether it occurs before, during, or after treatment. Additionally, how long the metastases occur after diagnosis is also important. However, the most powerful prognostic factor is whether you can achieve complete resection, as a complete surgical remission is essential for survival. Because of the importance of complete resection in both primary and metastatic osteo, and previous data showing that pre-op CT underestimates the number of viable metastases in up to 20% of patients, the traditional surgical approach has been open thoracotomy with palpation of all lung surfaces. However, over recent decades, thoracoscopy has become more popular for resection of lung lesions. This is because of decreased length of stay, less pain, and fewer adhesions, allowing for reoperation more easily. In osteosarcoma, small studies have shown that there are subsets of patients, such as those suffering late relapse and patients with solitary lesions at relapse, who are less likely to have additional lesions at the time of thoracotomy. Additionally, there is data such as a study in 81 patients showing that those with unilateral disease that undergo one-sided thoracotomy are equally likely to have contralateral or ipsilateral relapse. So these data and the decreased morbidity of thoracoscopy has led to an increase in the use of thoracoscopy. In fact, in a recent APSA survey, 34% of pediatric surgeons indicated that they prefer a thoracoscopic approach. However, a valid comparison of these techniques requires larger numbers and multiple centers. Thankfully, we now have the Pediatric Surgical Oncology Research Collaborative, or PSORC, which was started in 2016 and now includes 36 institutions. We welcome new members to join this collaborative, and if your institution is interested, please reach out to Roshni Dasgupta. PSORC retrospectively collected data on 207 patients with pulmonary mets and looked at only those who had their first episode of pulmonary disease. Demographics were similar between these groups, including clinical factors such as follow-up, the number of lesions, and whether there were negative margins. However, the one factor that was different was that patients with bilateral disease were much more likely to undergo thoracotomy. Outcomes were similar between both techniques. Disease-free survival was 33% with thoracoscopy and 29% with thoracotomy, while overall survival was 57% with thoracoscopy and 48% with thoracotomy. After adjusting for other variables with a Cox proportional hazards model, the hazard ratios for disease-free survival and overall survival were 1.01, with p-values of nearly 1. While this study is limited by its retrospective nature and the inherent selection bias of this design, the lack of any difference in survival between thoracoscopy and thoracotomy suggests that there is clinical equipoise. This therefore argues for the need for a prospective randomized trial. Unfortunately, using this data combined with some other recent studies, COG has already begun serious planning for a randomized controlled trial to answer this difficult question. So I'd like to thank APSA for the opportunity to present our research and for all the contributing institutions from PSORC for gathering the data. And again, if other institutions are interested in joining our nascent PSORC organization, please reach out. Thank you, and I'm happy to answer any questions.
Cynthia Reyes, Nemours, Orlando. Did any of these institutions use intraoperative ultrasound to look for these lesions?
Yeah, it's a great question. So localization techniques were, since this was a retrospective study, were really up to what the institution's practice was, and there was a wide range of what the localization techniques were. There were certainly some who used ultrasound, others used Copen wires or coils or methylene blue and all the different options. But I think it's safe to say that the vast majority of people who are resecting osteosarcoma pulmonary nodules with a minimally invasive approach are using some sort of localization technique. Yes?
Hi, Doug Barnhart from Salt Lake City, Tim. Thanks for the good presentation. I just had a detailed question for you. Obviously, there are probably many surgeons that try to individualize this based on the prognostic indicators in the patient, in particular the ones you listed, the response to therapy, how late the recurrence is, whether it's synchronous or metachronous. So obviously there's some bias in the data. Could you tell us, you mentioned that you did risk adjustment. Can you tell us more about how you did the risk adjustment and how much data you had for that, and any breakdown of how those patients actually partitioned out?
Yeah, so that's a great question. Thanks for asking it. The ability to do that risk adjustment is relatively limited with this retrospective data. But we did look at the timing of the disease and broken into 3 categories, so synchronous, and then early relapse and late relapse, because those really probably are 3 very different groups, with the late relapse group doing the best. And so that was our best attempt to be able to account for that, as well as accounting for the fact that there's whether there was unilateral or bilateral disease, because we know that those are probably the 2 most important factors.
Hi, LaQualia from New York. Again, a great study. I think it's important to emphasize, though, that the reason why it was done is to actually facilitate the development of an actual randomized trial in COG, and that this is a sort of a meta-analysis of data from multiple different institutions at different times and different risk risk statuses, as was pointed out by Doug. So I think that the importance is that the takeaway message should be try to get involved and have equipoise about the randomized trial. It's not necessarily true that every patient should have thoracoscopy for a metastatic osteogenic sarcoma.
Thank you very much, and I would echo that, and also sort of echo the encouragement once that study does open, which will hopefully be in the next year, to make sure that your institutions are participating in the prospective trial. So thank you.
Thanks so much. In the interest of time, we're going to move to the next paper. I'd like to invite Amy Lawrence from Nationwide Children's Hospital on behalf of the Midwest Pediatric Surgery Consortium to the podium, who will speak on understanding the value of tumor markers in pediatric ovarian neoplasms. Dr. Lawrence.
Good morning. We have nothing to disclose. The evaluation of a pediatric patient with an ovarian neoplasm includes components of history, physical exam, imaging, and laboratory testing. However, the role of tumor markers in this evaluation has not been well understood. The objective of our study was to describe the diagnostic accuracy of tumor markers in the preoperative evaluation of pediatric ovarian neoplasms. We performed a retrospective cohort study of girls 2 to 21 years of age who underwent ovarian surgery from 2010 to 2016 across 10 children's hospitals participating in the Midwest Pediatric Surgery Consortium. We then identified patients who had at least 1 concerning feature on imaging and at least 1 tumor marker tested. Concerning features on imaging included tumor size as well as other tumor characteristics shown here. Tumor markers included in our analysis are listed here. After identifying our cohort, demographics and clinical characteristics were described with frequencies, and sensitivity, specificity, positive predictive value, and negative predictive value were calculated for tumor markers and malignancy. Of the 819 patients who underwent surgery for an ovarian neoplasm across our consortium, 650 had a concerning feature on imaging, and of those 650, 249 did not undergo tumor marker testing, leaving us with a total cohort of 401 patients. This table shows the patient characteristics in our cohort by malignancy status. Overall, 19% of patients had a malignancy, but there was no significant difference in rates of malignancy by age, race, or ethnicity. The most common malignant pathologies identified were germ cell tumors, sex cord stromal tumors, and epithelial ovarian tumors. We then looked at the frequency at which tumor markers were tested in this high-risk population and found significant variability. As you can see, the most common tumor markers tested were AFP, beta-HCG, and CA125. We then looked at the sensitivity and specificity of each tumor marker. LDH had the highest sensitivity at 95%, but a low specificity at 13%, meaning that most patients with a malignancy will present with an elevated LDH, but many patients without a malignancy may also present with an elevated LDH. CEA, AFP, Inhibin A, and Inhibin B had the highest specificities, but low sensitivities, and the remaining markers had relatively low sensitivities and specificities. When looking at the positive and negative predictive values, we found that CEA, AFP, and Inhibin A had the highest positive predictive values, indicating that these tests, when positive, correlate strongly with the presence of a malignancy. LDH had the highest negative predictive value, but all other tumor markers had a relatively high negative predictive value as well, indicating that when negative, all markers had a relatively good ability to rule out malignancy. In conclusion, we found that tumor marker testing was highly variable. However, multiple tumor markers appear to be of value in preoperative risk stratification, but no single marker is sufficient. This is likely due to the multiple cell lines in the ovary that give rise to pediatric ovarian malignancies. Therefore, in patients with a concerning ovarian neoplasm, we recommend that a panel of tumor markers be used to aid in preoperative risk stratification and operative planning. This panel includes AFP, LDH, beta-HCG, CA125, Inhibin A, and Inhibin B. Unfortunately, the variability in tumor marker testing that we found did not allow us to definitively analyze the aforementioned markers as a panel. However, preliminary data in a small subset of patients who did undergo the full panel of testing in our retrospective cohort suggests that it may have high accuracy, as thus far we have found a sensitivity of 100% and a negative predictive value of 100%. Additionally, we are currently conducting a prospective study across our consortium wherein all patients with a concerning ovarian neoplasm will undergo the full panel of testing, and we look forward to presenting those results in the future. Thank you, and I'll take any questions.
Thank you for your presentation, Roshi Descapta from Cincinnati. Quick question about age groups. So if you think about patients that are post-menarchal, we think much more about epithelial ovarian tumors or borderline tumors. Did you parse out that group for potentially tumor markers that were more specific in looking at potentially prediction of those? And when you also mentioned epithelial tumors, did you mostly mean borderline tumors or did you mean other true epithelial tumors?
Thank you for your question. That's a great point about parsing out the age groups. As you may have noted, we did start our age cutoff at 2 years of age to exclude for neonatal tumors, but we did not evaluate for pre versus post-menarchal, but that I think is something, it's a great point that we should look at in the future. And for epithelial tumors, we did include borderline tumors as well as true epithelial tumors that we found.
Laura Galgansky from UC Davis. You had a large number of patients that didn't have any tumor markers, and so I was wondering what you can think about what the bias that is introducing and how that's going to play out.
Yeah, I think that's a great question. I think there could be two things contributing to that. So one could be, we did have a significant number of patients who presented with torsion, so there may have been some, or concern for torsion at least, so there may have been some urgency to the operation. But I think a more important point is that there has not been a standardization of approach to these patients with a concerning ovarian neoplasm. So as you saw with our variability in the tumor markers that were tested, there's variability in how people approach and proceed to the operating room with these patients, and whether or not that information was available to them at the time of operation is significant, I think. So.
Kathy Burnwhite, Miami. How much does this tumor panel cost, and how do you handle a tumor that looks like a garden variety mature teratoma?
That's a great question, and I don't know the answer to cost. I will have to look into that, and I'm sure it will vary by institution as well. As far as a garden variety teratoma, so we say that if it's a concerning has any concerning features, then we recommend that panel. So if all the tumor markers are negative, then you can proceed to an ovary-sparing surgery as appropriate. But if there is an elevated tumor marker, even when it looks like a garden variety teratoma, then we recommend that a multidisciplinary team be convened. If you have an adolescent gynecologist at your institution, we recommend conversing with them as well as the radiologist to really review the imaging and together coming to a decision for the best operative plan for the patient. So.
Thank you very much.
Thank you.
Next, I'd like to invite Maggie Westfall from Massachusetts General Hospital, who will speak on clinical appropriateness of pediatric benign breast disease management. Thanks, Dr. Westfall.
Good morning. Thank you for the opportunity to present our data here today. Let's see. This one. Our only disclosure is this project was recently accepted for publication. Pediatric breast disease often presents with one or multiple masses in pediatric breasts. These masses, though anxiety-provoking for the patient and their family, are most often benign, with the most common diagnosis being a benign fibroadenoma. Despite the benign nature of this disease, pediatric patients are often inappropriately treated using adult treatment algorithms. This includes the use of the BI-RADS imaging criteria, which has never been validated in pediatric patients. Given these issues, the treatment of the benign breast disease in pediatric patients remains variable across providers. In a recent study published in the pediatric surgical literature, the authors advocate for a clinical observation period. They suggest observing patients for several months with repeat clinical exams prior to any intervention. Though recommended, this algorithm is underutilized. However, it is not known to what degree. We therefore wanted to study the appropriateness of the management of pediatric benign breast disease by quantifying how often patients are appropriately observed, and when they were not, how often they underwent an intervention for disease that did not warrant removal. We first considered the definition of appropriateness and used the RAND classification for guidance, which states, an appropriate procedure is one in which the expected health benefit exceeds the expected negative consequences by a sufficiently wide margin. With this in mind, we completed a retrospective review of all patients presenting with benign breast disease who were less than 19 years old across 5 large academic hospitals. In order to determine the appropriateness of their intervention within a year from the date of breast mass diagnosis, we developed an intervention timeline. The observation interval was equal to the amount of time between the breast mass diagnosis and the patient's first intervention. This was set for 90 days in order to capture how many patients appropriately did not undergo any intervention within this time frame. The intervention interval was calculated by measuring the time between interventions for all interventions 1 year from breast mass diagnosis. Finally, we determined pathologic concordance to clinical decisions by reviewing the pathology of all biopsies and excisions within a year of diagnosis. Pathologic concordance was defined as disease that warranted removal, such as benign phylloides tumors, juvenile and cellular fibroadenomas, and intraductal papillomas, while pathologic discordance was defined as disease that did not warrant removal, such as fibroadenomas, hamartomas, adenomas, and lipomas. We evaluated 1,900 patients with a mean age of 16 years old and excluded 16 patients with malignant disease prior to analysis. We found 60% of our patients had fibroadenomas. This flowchart depicts our analysis of the appropriateness of clinical decisions. First, we assessed how many patients were appropriately observed for at least 3 months and found that was about half, or 54% of patients. We next assessed patients who underwent an ultrasound and analyzed ultrasounds that were determined to be suspicious and found that 70% of patients appropriately underwent further evaluation with biopsy or excision. However, assessment of the final pathology of these specimens determined that 83% were pathologically discordant, again, meaning the disease that did not need to be removed. Looking at ultrasounds that were not suspicious, 15% of patients inappropriately underwent further evaluation with biopsy and excision, and these were found to be 86% discordant. Finally, when looking at patients who underwent biopsy or excision as their first intervention, again, 78% of patients had pathologically discordant disease. In summary, 81% of all interventions were found to be pathologically discordant. These patients underwent a biopsy or an excision for disease that did not warrant intervention. Given that much of the literature related to pediatric breast disease is in fact radiology literature, many studies of this patient population recommend the use of ultrasound for assessment of all patients. However, when we compared the positive predictive value of ultrasound to clinical suspicion alone, these two methods were not significantly different in their ability to predict disease that needed intervention, with positive predictive values of only about 20%. Overall, in our patient cohort, we found evidence of the overtreatment of pediatric benign breast disease, with 80% of patients undergoing a biopsy or an excision for disease that did not need to be intervened upon. By comparing the positive predictive value of clinical exam to ultrasound, we did not find any difference in either's ability to accurately predict patients that had disease warranting removal. Finally, given the ongoing variability in disease management, it remains clear there needs to be an evidence-based clinical practice guideline to help providers manage breast disease in this population. By focusing on an observation period of at least 3 months, we believe many patients will be protected from an invasive intervention that may lead to permanent disfigurement, given the sensitivity of adolescent breast tissue. We advocate for consistent education of patients, their families, and primary care providers, and have found that many patients who have previously pushed their providers to undergo an intervention are more comfortable and in fact prefer undergoing repeat clinical breast exam after a clinical observation period. Given that 80% of suspicious ultrasounds were pathologically discordant, and most of these ultrasound noted a BI-RADS 4 classification, we believe that the BI-RADS classification is not appropriate for use in pediatric patients with benign breast disease. Therefore, what should the algorithm be for identifying patients with breast masses that should undergo an observation? We believe the focus must be on a clinical observation period and recommend multiple measurements by the same physician over time. We are currently examining the possibility that perhaps growth over time is the true predictor in identifying patients that should undergo invasive intervention. And thus, this should be the treatment recommendation for surgeons who manage this problem. I would like to thank my research mentor, Dr. Kelleher, as well as my co-authors, Drs. Numa Perez, David Chang, and Yaching Hung, and can take any questions at this time.
Yes.
Yeah, Walt Andrews from Kansas City. Thank you very much on an excellent presentation on something that certainly is vexing for us who see patients in clinic with this issue, and certainly with mothers who usually almost always seem to have a relative that's had breast cancer. One thing that we've utilized a lot, and I wasn't sure when you made the included in biopsy, we use fine needle aspiration as a means to be able to sort of help if you will, decrease the concerns that the parents may have. And with that, if that comes back benign, which it almost always does, then we can just follow them over time and hopefully they will resolve. But I was wondering, was there any role in your study for fine needle aspiration?
We included that as long as it was a fine needle aspiration for solid disease and not cystic disease. We included it in the biopsy category, but again, obviously, fine needle biopsy over a core biopsy would be better for the concerns of disfigurement, as you said.
I'm sorry, in the interest of time, we're going to need to move to the next presentation. Thank you so much for your talk. I'd like to invite Callista Harbaugh from the University of Michigan, Ann Arbor, to speak on the development and implementation of a competency-based curriculum in pediatric surgery. Thanks.
Thank you for the opportunity to present this work. This is funded by the GME Innovations Grant at the University of Michigan. Currently, fellowship training is based in time rather than content learned. In effect, we assume that learning occurs rather than ensuring in all ways, in objective, measurable ways. Moreover, decreased autonomy and underpreparedness for future practice remain concerns among surgical trainees. To address this, we aimed to establish a model for graduated autonomy to ease the transition into faculty using a competency-based training curriculum for pediatric surgery fellowship. To do this, we first obtained faculty consensus on 3 procedures that were not complex and were high volume enough to use for a proof of concept. Then we defined entrustable professional activities, or EPAs. These are the key tasks that must be mastered to ensure competence. Linked with the NADA textbook, these form the basis of a pre-, intra-, and post-operative curriculum. Then we created a host of assessments to measure progress. These include an operative evaluation, case minimums, a board-style oral exam, a communication assessment tool that assesses the interaction between fellows and families, and an external review of an unedited operative video. To implement this, we longitudinally engaged faculty and fellows. This graphic demonstrates the process. The fellows drive the curriculum. They solicit evaluations from faculty, and they complete their own set of EPAs. When the evaluations and the EPAs are complete, they can request to sit for the oral exam. All of this objective information, combined with faculty consensus, goes to the Clinical Competency Committee. They decide when the fellow is ready to submit for an external video review. And if the review is deemed positive, then they are deemed competent for that procedure. Here is the first fellow's progress with laparoscopic pyloromyotomy. As you can see here, they met their total case minimums for both total and autonomous cases by the end of their first year. They completed the rest of the curriculum by July of the second year. The CCC then produced a letter certifying their competence for this procedure and encouraged faculty to allow greater autonomy within their comfort zone and within legal bounds. 3 fellows have initiated this pilot. We send a weekly progress update to all faculty and fellows. Each column here represents a component of their curriculum. The first fellow had completed the program, the second fellow is nearly complete, and the third, a first-year fellow, is progressing quickly. After completion of the program, the first fellow completed 5 pyloromyotomies, 5 appendectomies, and 6 inguinal hernia repairs after deemed competent. The fellow described their experience. In a fellowship where I felt that I already had excellent autonomy, CBT added structure and identified areas for improvement, particularly non-clinical competencies. Specifically, the pre- and post-op conversations with the family were more deliberate, knowing that I was the final arbiter and truly seen as the surgeon. The fellow also described the process of buy-in. There were varied levels of comfort on the part of the faculty initially, but once the progress was fully introduced, they embraced it and helped me focus on particular parts of my assessment. Their behavior was overwhelmingly positive in ruling out the CBT, and I feel that it enhanced the level of trust that they had in me. Throughout the process, we've met several challenges and learned many lessons. I will share 3 of those. First, to promote fellow and faculty buy-in, we alleviated administrative burden by developing electronic platforms or using electronic platforms that were on handheld devices. We also engaged the fellow and faculty in working through all of the kinks in the process. And finally, we allowed the program time to demonstrate its own value. Second were evaluations. We initially used an OPRS-like operative evaluation. It was comprehensive, but because of the volume, it became burdensome. And so we've since moved to a more Swish-like streamlined global app that also includes enhanced prompts for the open-ended statements at the end to promote formative feedback for the fellows. Lastly, is we've made CBT work at our institution, but we're now working with other institutions to identify opportunities to generalize the workflow, and future steps will also include expanding to additional procedures. Thank you to everyone who's made this process possible, and a special thank you to Dr. Azro, Dr. Arca, and Dr. Powell for their external input. I'll take any questions.
What are your plans to expand to other procedures?
Yeah, that's a great question. So you can go in 2 ways. One is you could include additional sort of simpler procedures, things like lines or G-tubes that are high volume, and a second is to think about more complex procedures. Certainly the complex procedures bring additional concerns around the number of cases that one might complete in fellowship and whether they would truly be able to be competent and independent by the end of fellowship. So next procedures, we're working with our other partner institutions to identify what everybody thinks will be the highest value procedures to expand to.
Yes.
Yeah. May I just ask, this is really innovative. The question I have is, have you compared this sort of work with simulation type of training? And is the learning enhanced or not?
Mm-hmm.
Do you have any data on simulation versus this more structured environment?
I think that's a really excellent question, and the way I might answer is that I don't think they're mutually exclusive. I think they sort of have different goals and probably complementary. I think nationally we are starting to move towards competency styles of training and education. In Canada, the orthopedic programs are already using this model, and they've actually sort of changed the time spent in training. We're not advocating for changing time. We also know that in the general surgery, I'm a general surgery resident, but they're starting to pilot EPAs, although they're mostly piloting feasibility as opposed to implementation at this point. But I could see how simulation may play an important role if we're trying to objectively measure technical competence, for example. We have not incorporated it into our curriculum, and I don't know that that'll be the next step, but I think it's a really important question and potential future direction. Thank you.
Bassem Khalil from Sidra Medicine in Qatar. Your program is very, very similar to the United Kingdom's ARCP program, the Annual Review of Competency Progression. Have you actually looked at the ARCP program of the UK and to see whether you could actually gain some things from it into this beautiful program of the CBT?
Yeah, thank you so much for highlighting that. I think you highlight a really important point that people are going towards this model and have already gotten farther along than we have in the United States in pediatric surgery. So we've certainly reviewed all of the programs that we've been able to find out there in this process and have been making tweaks and adaptations to learn what lessons we can from the work that's already been done. So thank you for highlighting that.
Thank you very much.